this is a quick case where I'm presenting right now, which is a 32-year-old lady, severe rheumatoid arthritis, multi-joint involvement, and you can see her activities of daily living are severely affected. We're looking at the right side. The ROM was 10 to 85, 10 degrees of FFD, no distal neurovascular deficit, and you can see that there is a malformed femur in this particular patient, and then the left side was probably done 2 years ago in an outside hospital. So if you look at the scanogram, this is the initial HKA axis. The LDFA is around 66.2, MPTA is 83.9, and you can see that the CORA has been calculated to be 23.5, and it's in the metaphyseal region. So the questions that we wanted to discuss is, what is your management plan? Would you want to do this as an intra-articular versus extra-articular correction? What is your indication? Is there a role for technology like robotics in such a patient? And what would be your implant choice?
Can you just go back to the last X-ray? So did she have a fracture?
So my sense is, I think this, she had so much of osteoporosis. You can see that. So I think the lateral side almost buckled. So there is no obvious history of trauma in this particular patient.
So someone on the panel want to tell us what they see on that X-ray and what they think about that case?
Well, I do still think that there must have been a fracture which is joined in that position. The amount of deformity, I think, is probably just outside the range where I could correct it intra-articularly. The
So
deformity is...
What's your threshold?
Well, I would actually draw the line, a 90 degree to the mechanical axis, and see where my cut is going to be. If I'm going to be on the impinging onto the lateral collateral ligament, I would cheat in these patients a little bit. I would put them in a little bit of
So this is
varus.
valgus. So you mean the MCL, you don't want to cut off the medial epicondyle.
Yeah, that's right, medial on this particular
medial
one.
epicondyle.
So I would cheat a little bit by putting the component on valgus on the femur and a little bit of varus on the tibia, but I think this is probably out of that range. Somehow the opposite side is managed. Probably the deformity was lesser, but that's my first impression looking at this, that this might need... The other problem is that you try and correct it in one stage, and if you need a stem on the femoral side, you might find it difficult to actually negotiate it.
So anyone else want to make any comments on that?
So what are the parameters that usually we want to see based on which we decide whether to do an intra-articular versus an extra-articular correction? So one was the quantum of deformity.
And you
the location,
the proximity to the joint. So this particular deformity is quite close to the joint. So if you try to do anything, intra-articular correction, then it will probably not be good for the soft tissues.
So this is the table that I made for intra-articular versus extra-articular. So anything less than 20 degrees in the coronal sagittal plane on the femur, 30 in the tibia, and the location of the deformity is very important. So if you see, this is the formula that is used. The closer the deformity to the joint, the more relevance it has. And you can see the same 20 degrees, if it is far away from the joint, then it only actual impact is 8 degrees versus if it is much closer, it's around 16 degrees. All multiplanar deformities with limb length discrepancies would need an extra-articular correction. And the other points that were mentioned is if you're compromising the ligaments on either side when you're doing a 90-degree cut, then I think it is more in favor of an extra-articular correction. So here, these are the three parameters that what made me feel during my initial assessment that because the deformity is more than 20, it is much closer, and then if I made a 90-degree cut, I would definitely most probably compromise the ligament. So that's one piece.
So that's a great, should we ask the panel what they would do?
Yes.
So how are you going to correct that deformity? Dr. Shetty?
I guess I'll be doing it conventional, this one. I won't go for robotics in this because the bone is very porotic over here. I have my own concerns about putting the pins over here, and I might go conventional in this case.
And so you'll do an osteotomy?
Osteotomy.
Where would you do the osteotomy?
At the CORA.
At the CORA. Okay, and you're just going to fix it with a long stem femoral
Long
component,
stem,
or
but
are you
the
going to?
only conflict
plate
is
as
there's
well?
a hip over there, there's the only conflict, so I may put a stem and I'll put a plate around over there.
And are you going to do a closing wedge or some other?
Closing wedge.
Okay. Anyone else do anything differently on the panel?
Any role of technology, if you want to use, you think how would technology help you in?
Would you use, David, you use a robot, I'm guessing.
I was going to say I'd have Anil come show us one of those fancy 3D printed custom cutting
Okay.
guides we saw yesterday for the osteotomy. I think this is going to be complicated to fix.
Yeah.
I think this patient needs an osteotomy to fix this. Personally, I would probably do this in a staged fashion. For some of the reasons we talked about. If you do this one stage, you're going to have to put a long stem to fix the osteotomy. Then you're going to have two stems that are basically abutting each other. Then you're going to be worried about an intraprosthetic fracture. So I would have one of our deformity guys fix the deformity first.
So
and then come
that'd be
back.
a supracondylar osteotomy in the distal femur with a medial closing wedge or opening wedge or some other chevron or something?
These people have enough trouble healing. I'd probably be doing a closing wedge, not an opening wedge.
Yeah. Okay, do you want to continue?
So quickly, I want to summarize. So looking at the social fabric in Indian patients and affordability, most of the time we would try to do an intra-articular correction, or we would try to do a one stage where we do the osteotomy and the whole gambit of procedures in one go. And the way technology can be used in such systems is you'll have real-time feedback about how correction has to be made. Number one, you will know the soft tissue tension which is not there prior, and then you can decide on the level and how the osteotomy needs to be done. And little bit of implant maneuvering will help you to reduce the amount of soft tissue releases. So this is the plan that I went in with. And to my surprise, you can see on the left, this is the initial assessment. The overall HK axis was 11-degree valgus, and then with little bit of release, actually the limb came down to almost 1-degree valgus without much correction. So in other words, there was a soft tissue component which we didn't know before we went in. So all that we had to do was we had to raise the tibia because there was 1.5 millimeters of gap on the lateral side. So we raised it up, gave a degree of valgus, 3 degrees of internal rotation because the flexion medial was for some reason tight in this particular patient. And that is the end result of the patient. Do you guys notice anything different in the implant that I used? One of the big reservations with the Stryker system is I would have had to use a TS femur if I have to use a stem. And this lady, if you can see this is the one triathlon femur that itself is too huge. So I had a lot of reservation in using the Stryker implant. So what I did was I used a mid-resection workflow. I had the debut implants as a backup. I did the distal femur cut, tibial cut. I balanced out the extension. Then using the robot, I make the mark on the flexion side for the cuts, which were 8 millimeters and 4 millimeters with the degree of rotation. And after marking that, I used a 4-in-1 cutting block from debut in order to reproduce that. And this way I could just get away with a PS femur with the stems on both sides.
Okay. Thank you very much. Any comments from the panel? Is that your last slide?
So this is just a conclusion slide of what we discussed.
All right, thank you very much. Congratulations.